Good afternoon, everyone. We welcome all for today's NDLS session. Today's topic is LAC and LAC Plus Guidelines, Monitoring, Issues and Experiences till date. And presenter is Dr. Sudhir Chawla. He is currently working as a Joint Director at Gujarat SACS, Ahmedabad. He has obtained his MBBS degree from SP Medical College, Bikaner, and also completed postgraduate diploma in maternal and child health from IGNOU and diploma in public health from Medical College, Vadodara. Then he worked as a district program officer for HIV/AIDS at Bharuch for 2 years. Then he served as in charge of epidemic medical officer and additional district health officer for some period in Bharuch itself. With the NACO sponsorship, he has completed his postgraduate diploma in HIV medicine from IGNOU, and also he completed some distance learning courses from University of Washington. He is a SASAP member of COE BGMC Ahmedabad, ART Plus Centers of Gujarat. He is also a master trainer of HIV and ART. Now I request Dr. Sudhir Chawla to take over the session. Thank you.
Okay. Good afternoon, everyone. Today our topic of presentation is Link ART Center guidelines and experiences till date. So during the session, we will discuss about the referral and linkage procedures between HIV care facilities, rationales for establishing Link ART centers and LAC Plus, objective and function of Link ART center and LAC Plus centers, infrastructure, human resources, SOPs for patients coming at ART LAC and LAC Plus, and job responsibility of the staff working for the Link ART center, and the monitoring issues which we are facing during our regular visits and experiences till date. First of all, let me understand about the referral and linkages between the different HIV care facilities. Once a patient is diagnosed as HIV positive at ICTC center, he or she should be linked to the ART center for the necessary lab investigations, clinical evaluation, and based on which the ART can be initiated if patient is found to be eligible. So, if a person is started on ART and doing well with the ART, after more than 6 months of ART treatment, if patient is doing well, there is improvement in CD4 count, weight is gained, there is no active OI. In that case, patient can be linked to the center nearby, which is known as Link ART center. So from where the patient can collect their monthly drugs. And there are some Link ART Plus centers which can also enroll patients in pre-ART care. We will discuss these things in detail in the subsequent slides. The patients on first line therapy, those who not respond well, or those who failed on first line or having any side effects with the first line, can be sent for the expert opinion to the Center of Excellence or the ART Plus centers, where they can decide about the alternate first line or the second line regimes. From all these facilities, ICTC, LACs, LAC Plus, ART Center, COEs, if there is any patient suspected with having tuberculosis, these patients can be referred to the RNTCP sites for the tuberculosis diagnosis and treatment. Similarly, there are some patients, those who are diagnosed with TB first and then referred to the ICTC for the HIV testing, and if they found positive, they will link with the ART center. So there is a cross linkage between RNTCP and NACP facilities. There are few other facilities which are known as care and support facilities. These facilities are basically run by the NGOs, and they are mainly meant for the provision of care and support related services for the PL-HIVs, because we understand that ART centers, we are able to provide treatment services, but somehow we are not able to provide care and support services as which is required by the PL-HIVs. So for the better provision of services, for the quality provision of services, we link them with the care and support centers. And other important work of care and support centers are like those patients who are lost in between the track from ICTC to ART center, or even after registered with the ART center, if they lost treatment, what we call as lost to follow up. So these patients can be tracked by the care and support centers for getting them back under the system. Now coming to the guidelines for the Link ART center. Before going into a guideline, let us discuss about the rationales behind link AT center. Why we established link AT centers? Basically, when a patient is initiated on ART, he or she have to come at ART center every month for the monthly pickup of drugs and for the clinical examination, on which we can decide whether patient is having any new OI or what is the CD4 count. We are regularly monitoring CD4 count. We are doing regular some lab investigations also. We are counting the remaining pill balance, so that we can know about the adherence of the patient, how much they are adhered to the treatment. So these all things are being done on monthly basis. Patient have to travel to the IAT center. Mostly IAT centers are placed at district level or the medical college level hospitals. So it was found difficult for patients to travel every month for this testing and examinations and for collection of drugs to the district level hospitals. And because of that, there are some increase in loss to follow-up cases and death. There are some genuine things like there are adverse weather conditions, with the natural calamities. They may not be able to come regularly every month, and they may be like something. Sometimes patient have to have some accompaniment to go to the district hospital. So this may lead to the escalation of the cost in addition to the travel cost. So considering all these factors, to minimize the travel need of the patient, stable own ART, having better drug adherence, NACO decided to establish Link ART Center since 2008. So these are the centers which are basically situated in the sub-district level hospitals. They are integrated in the national health system with the help of trained persons from the state and national level. The capacity of healthcare provider at primary and secondary healthcare level hospitals where the Link ART centers were established, their capacity was built up. The gap between ICTC and CST was decreased, and ultimately access to the ART services is increased up to the sub-district level hospitals, and this may reduce the travel cost and travel time and ultimately improve the adherence of the PLHIVs. So these were the objectives behind initiation of Link ART centers. As far as functions of Link ART and Link ART Plus centers are concerned, main function is to provide ARV drugs to the stable PLHIV already own ART. They are not having any OI, they are not having any active OI when they linked with the Link ART center. They are doing well with the current regime, their adherence is good. They are just coming for the regular drug pickup and the routine examinations. So basic function is to provide ARV drugs to the stable PLHIV on ART. Do the adherence counseling on every visit. Even though they are having good adherence, we have to do the adherence counseling on every visit. Monitor them for the drug side effect or the occurrence of any minor OIs and treat symptomatically. If there is any major OI, they can back refer this patient to ART center. Sometimes PLHIV may need some psychosocial support by the hospital staff. So we already have a counselor working at the hospital which is known as the ICTC counselor. So he or she is working for the Link ART center. So the psychosocial support can be provided by the counselor. Then in each and every visit at PLHIV, they are at risk of having TB infection at any time of during the course. So they should be screened for TB on every visit, and if found symptomatic, they can be linked with the RNTCP sites and with the ART center back for further treatment. TB treatment may be provided by the hospital itself. And if it is a LAC plus center, then some pre-ART patients may come to the center and they have to manage pre-ART patients also. If patients own ART or pre-ART patient, they miss in between, there are loss to follow-up, then these patients have to be tracked by the care and support center. So LAC have to establish a linkage with the care and support center for tracking these miscellaneous cases. Telephonic tracking may be done by the LAC counselor for early recovery of these patients to the into the program. So what we understand is ideal site for Link ART center will be the place where it is a government hospital. It may be in taluka level or CSC level hospital, having ICTC already established ICTC center, having a counselor, so that ICTC can be working as a Link ART center. So the counselor of ICTC can be working as a link AIT center counselor. So each LAC will be linked with the closest nodal AIT center from where the patients can be linked with them, and each LAC will have one nodal AIT center, but one AIT center may have more than one link AIT centers where they can link as per the geographical distribution of the patients. As far as infrastructure is concerned, there is no any additional infrastructure required because already existing, working staff at the hospital is working for the link AIT center. Like the medical officer of the hospital will be the LAC medical officer, ICTC counselor will be the link AIT center counselor, staff nurse and pharmacist of the hospital will work as they are working for the other patients. But for the record keeping and other LAC function, one additional room may be required, and rest of the infrastructure is already there in the hospital. There is no any additional infrastructure required. Computer system is already available with the ICTC. If there are issues of broadband internet connection, there are separate funds provided for the internet connectivity for link AIT center. There is a general OPD in the hospital where the all other general patients are coming. So these PLHIV can be attended in general OPD of the health system by the hospital medical officer. As we discussed, there is no additional manpower provided. Working medical officers in the hospital can be trained in the LAC function. ICTC counselor, hospital nurse and pharmacist and the other hospital staff can be trained. There is a standard induction training program for link AIT center medical officers for 3 days and one hands-on training of 2 days for the entire LAC team, that is medical officer, counselor, nurse and pharmacist at the nodal AIT center. After these trainings, we can initiate link AIT center. Working hours. So whatever is the working hours for the OPD of the hospital, whenever the hospital is kept open, the OPD is kept open, the link AIT center should be open. If the hospital is closed on a holiday, the link AIT center will also be closed. So it will follow the hospital OPD pattern. Whatever time is convenient for the OPD of the hospital, that same timing will be for the link AIT center. Now coming to the experience, what we understand from the field. This picture is of a medical officer of a hospital who is prescribing treatment to some of the patient. This patient is not a PLHIV. This is just a patient coming to the hospital. Doctor is prescribing treatment. So this doctor is prescribing treatment without knowing any disease of this. She is examining, she is deciding on the diagnosis and then she is prescribing. So she is not knowing, before patient came to her, she is not knowing about the diagnosis, what this patient is suffering. She examined, she do the some lab investigation, come to the diagnosis and give the treatment. This is again two different pictures of a hospital medical officer. In this first picture, the medical officer is surrounded by a lot of patients. This medical officer not knowing about which patient is suffering from which disease. He is still surrounded by these all patients and doing his work very nicely, very calmly. He is treating all of them. He will complete his OPD and treat all of them with the satisfaction. Now this medical officer is doing treatment for the pediatric patients. He is a simple MBBS doctor and doing treatment for the pediatric patients. This is not his routine OPD. He is sitting in the field and examining patients and treating them. Like PSC medical officers doing the field visits, it may be like that. This is like this medical officer is examining a patient, doing blood pressure examination. Here is something like they are giving some injection or taking some blood samples. Here is a picture of medical officer treating indoor patients. Now the question is, if a medical officer can do all these things in the patients for which they are not knowing about their status, they can examine them, they can treat them, they can treat in emergency, they can treat the lot of patients coming together. They are mass emergencies. They are surrounded by a lot of patients. Still, they are doing treatment of every patient, whatever disease they have, whatever diagnosis they have, whatever best possible is at the medical officer level, they are doing. Now, the question is, These PLHIVs, those who are referred, those who are linked from the ART center with the link ART center, don't go with the name of link ART center. I will say that PLHIV own ART linked with the hospital where it is designated. This hospital, which is a CSC or a district level hospital, is designated a link ART center. This hospital is catering services for all other patients. Now these own ART patients, those who are already stabilized with a minimum period of 6 months at nodal ART center, they exhibit weight gain, they are having increase in CD4 count, they are not having any active OI, they are confirmed as a PLHIV. So we are clear that they have HIV infection, but there are no active OI. They are doing well with this treatment, and they are residing closer to the hospital where this link ART center is situated. These patients, when they come to the hospital, who will treat them? Who will prescribe medicine to them? We know these are HIV patients. We can be careful about the route of transmissions. Otherwise, also we have seen in the previous pictures, doctors are taking due care in the patients which they are not knowing about the status. They are wearing gloves. They are following universal work precautions. So in these patients, they are knowing the PLHIV. They are knowing that these patients are HIV patients, and they are not having any active OI. They are on treatment, established, and doing well on the treatment. They are just there for the routine examination and for the monthly drug pickup. So who will prescribe medicines to these patients? Is it so difficult to prescribe medicines to these patients? I am asking to the participant whether it is so difficult to prescribe medicines to this type of patients by a medical officer who is doing lot of other work, but not able to. Is it so that they are not able to prescribe medicines to the patient, those who are PLHIV already on ART? My question is to the link ART center doctors, if they are there, please, any of the link ART medical officer, please respond. Is it too difficult? It seems that no link ART center is logged in. Is there any link ART medical officer? Okay. Now, what we expect from the link ART medical officer at the monthly visit of patients? What medical officer have to do? Examine these 4 parameters which are known as W, that is weight of the patient. In case of children less than 5 years, you have to measure the height. Adherence, treatment adherence have to be measured, and adverse effects, if there are any drug adverse effects, that is to be monitored, and if there is any OI, and if it is a minor OI, they can treat it. If it is a major OI, they can refer this patient back to the ART center. So only 4 things have to be done: weight, monitor adherence, examine for adverse effect, examine for OI. So above 2 things, that is weight of the patient and treatment adherence, then that can be done by the counselor. The question is, who will examine patient for the adverse effect and OI, and validate about whether there is a patient, the weight and the treatment adherence, what happened to these things, whether patient is having optimum adherence or not, and whether there is any increase or decrease in the weight. Is it significant to the level that patient may need some expert opinion about the failure of the regime or not? So that decision has to be taken. So who will do this thing at link ART center? Who will examine and prescribe medicines to the patient at link ART center? Examine for the presence of OI, examine for the adverse reactions, examine for the adherence and any change in the weight. Who will do all these things? Medical officer. But do we think that medical officer, CSC medical officer, district hospital medical officer, where the link at a center is situated, they are able to do lot of other things, but they are, is it like they are not able to prescribe this treatment? They are not able to do these 3-4 things, which are very simple. OI examination means examining patient for any illness. Adverse reaction, there are 2-3 known adverse reactions which can be examined by the medical officer easily. So what a big deal in this thing? Why people are not able to do this examination and prescribe treatment? This is one of the link at center. When it was started, this medical officer was doing very nicely, and now this center is converted into AIT center, and he is a nodal officer of the AIT center. Now look at the other scenario. ICTC counselor, they are prescribing, they are treating patients, and there is a queue in front of the room of ICTC counselor. Do we doing it in right way? Whether ICTC counselor is a person who can prescribe and treat prescribe treatment to the PLHIV? Is it right ethically? So what we understand is link at a center have to take the ownership for PLHIV in the similar way what they are doing for the other patients, even in the absence of knowing their disease status. They are doing very well, they are treating them. So why not they can do this thing with the PLHIV when they know that these are the HIV patients and these are clinically stable on this treatment. Now coming to the dispensation of drugs at LAC. Who should dispense drugs at the hospital? At a hospital where link at a center is situated, who have to dispense the drugs? Drugs have to be dispensed by the institute of pharmacist. No, I am talking about the institute where the general medicines are there. General medicines, who is dispensing general medicines of the hospital? That is pharmacist. These pictures are showing that pharmacist is dispensing all the medicines. This first picture is showing that these are the some capsules, maybe like TB treatment was there. These are the lot of medicines were there. The patients are there in the queue, and pharmacist is dispensing medicines, all the medicines. But when it comes to the HIV medicine, that is ART, who will dispense? Counselor or the pharmacist. Why? Is it the right thing? Can they dispense? Why not pharmacist dispense these medicines? That is the question. Why pharmacist is not willing to issue these ART tablets? Why they are not willing? What is the issue? Why they are fearing about? Is there any fear about the side effects of the PLHIV patients? They will give the medicine, they will get some infection. Is it like so? What is the problem? We should know that problem. Why pharmacist who is giving medicine to every other patient except HIV patient, why they are not able to dispense these medicines? So there pharmacist is there in the hospital dispensing all other medicines. They can dispense. There is not a big deal in dispensing these medicines. These are coming in the bottles. You can see these are the bottles and have to be given once in a month only. These are not the strips, and not like they have to be counted for the days. The counting and adherence thing, that can be done by the counselor, but dispensation is to be done by the pharmacist. So with this in background, now we understand that there is no much problem in dispensing or prescribing treatment for the PLHIV as far as LACs are concerned. Already clinically stable patients are coming, and they can easily be prescribed, and they can easily be given the medicines as for the other patient the hospital staff is giving. Now coming to the revision of the scope, why we converted LAC to LAC plus. It was observed that there are some 20% patients who were detected HIV positive at ICTC. They did not link with the CST services, and those who reached at the AIT center, out of that 20% of them were reached very late, that is at the CD4 count less than 50. So they are at risk of mortality, which are 3 times higher. So considering these facts, it was understood that the sub-district level hospital where the link centers are situated, they are not able to register patients when they come positive from the ICDC. They may not register these patients because once patient have to go to the ART center, and minimum after 6 months of own ART and clinically stabilizing, these patients can come back to the LAC. So this dropout may be because of because the patient was diagnosed positive and have to go to the district hospital for the further treatment initiation. They are not going because they are feeling well and they are not asymptomatic. They are not feeling any emergency for the treatment, and they just avoiding hospital visits because of the long distance or the some time. Lot of time will be wasted in the hospital. So considering these facts, some of the link AT centers were converted to LAC plus where the patient load of own ART patient is already more than 70. So at LAC plus, in addition to the function of link AT center, patients can be enrolled in HIV care as a pre-ART patient. Basic workup, that is baseline investigations and CD4 testing through linkages can be done at this LAC plus. Those who are in pre-ART care will be followed up till they become eligible. At LAC plus only, there is no need to send these patients to the ART center. Once they become eligible for ART, definitely ART will be started from the ART center only, and they will be linked to the ART center for the same. Line listing of HIV TB cases, those who are coming from the LAC plus visits, and tracking of patients, those who are lost to follow up in between. These are the some work in addition to the LAC work. So where the more than 70 own ART patients were there at LAC, these LACs were converted into LAC plus with the additional provision of staff nurse. This staff nurse is recruited on contractual base from the NACO fund, and the salaries are being given by NACO fund. This is our Gujarat experience, upgradation of LACs. We have initiated 75 LACs till date, till March 2016. Out of that, 59 are currently functioning at link AT center. 7 are upgraded to LAC plus. As of now, there are 7 LAC plus. 2 are converted to FI ART center, and 15 are converted into ART center based on the patient load and the existing guidelines. LAC plus we started 9. Currently we have 7 LAC plus and 2 are upgraded to 5 FI ART center. As in recent year, the further expansion of the program is on hold, so we are not able to increase LACs and LAC plus, but there are few sites which can be converted into LAC plus. If this will be permitted by NACO, we will be able to convert these LAC plus. Coming to the M&E tools which are to be maintained at LAC and LAC plus, I am just touching on the name of the tools which are to be maintained at LAC, LAC plus. Like ART enrollment register, it is the same register, that is ART register, which we popularly known as own ART register or the OT register, what we call. It is to be maintained by the counselor of ICTC and LAC. White cards, it is to be filled by the medical officer and counselor. Green book to be filled by the medical officer and staff nurse. LAC drug stock register, there is not much thing to be entered in the drug stock register. Number of patients, though there are few medicines, few regimes on which the number of mainly all the patients are within first line. So there will be 3 or 4 different type of regimes. Their stock have to be entered in the drug stock register, and similarly in the drug dispensing register. There is one monthly reporting format which is to be sent by the LAC medical officer. That is a self-explainable, easy to understand monthly reporting format, which can be filled on monthly basis by the LAC MO. There is one format, that is Annexure 4B for the filling up of records at ART center for the patient, those who are linked with the LACs. But their records at ART center is to be filled up based on this information given in the Annexure 4B, which is to be filled by the LAC and LAC plus. And electronic copy of link in form and link out form is to be maintained both at LAC and ART center. at LAC Plus, in addition to the tools which are maintained at LAC, there is, as the patients in pre-IAT care can also come at LAC Plus. So pre-IAT register is to be maintained by the, now we have given one staff nurse, additional staff nurse, so that have to work for the pre-IAT register completion. Similar to the 4B format, about the line list of OAT patients. Similarly, there is a line list of pre-IAT patients, which is known as 4C, and CD for lab transport register, lab sample transport register, which is to be filled by the lab technician, and HIVTB register, which is to be filled by the staff nurse. So this is 4C and there was 4B. What about 4A? What is 4A? Anyone having any idea about 4A? Yes, 4A is, this is our LAC monthly reporting format. This is known as 4A. So there are three format basically. If it is LAC plus, if it is LAC, there will be only two format, 4A and 4B. If it is LAC plus, they have to fill the three format A, B and C. How patient will travel when patient will go to the LAC? What will be the flow of OAT patients? Patient will have to be registered in the OPD counter as per hospital requirement. Then ART enrollment register and white card will be filled up by the counselor of the LAC and the hospital staff nurse. Then the record will be computerized by the counselor and staff nurse, and patient will be sent to the medical officer of general OPD, who will examine and prescribe medicine, and then patient will be sent to the pharmacist, where drugs will be dispensed, and the white card will be retained with the pharmacist, from where counselor and staff nurse will take this and put it in lock and key, and patient will go back to home. So we can understand that for each and other disease, there is a system. When patient come to the hospital, there is a window from where they collect their case paper, that is OPD window. So similarly, at that point, the PLHIV will get registered with other general clients. From there, they go to the general clients go to the doctor directly maybe, but in this case, they will go to the counselor first, get their white card and green book filled, appropriate the columns in the white card and green book which are to be filled by the counselor. They will fill it up, and they will do the adherence counseling and check the adherence, and do the weight, and provide psychosocial support and do other counseling, whatever is required, and then send this patient to the medical officer for the clinical examination and prescription. Similarly, for other disease, what medical officer is doing, he will just examine, and if there is anything wrong and want to be treated, they will prescribe medicines and send patient to the pharmacist for the ART and the other medicines. So how patient come to the Link ART center from ART center, that we discussed. Now patients are there at Link ART center, and there are few things when patient have to go to the nodal officer, even though they are taking treatment from the Link ART center. What are these conditions? One is, every 6 months patient have to be, even though patient is started on ART, is doing well on the ART, but we want to know about the CD4 count. We want to know how patient is responding to the medicines. That we can know with the help of CD4 count monitoring. So we are doing every 6 months CD4 count in all on ART patients. So those who are initiated on ART, those who are at Link ART center, they have to undergo CD4 testing every 6 months. So these patients have to be sent to the ART centers for their CD4 testing at 6 month interval. In the month of CD4 testing, we should be careful at Link ART center that medicines will be dispensed by the Link ART center only. There will be no dispensation from the ART center. ART center will do clinical examination, do the necessary investigations if required for diagnosis of any other OI, and do the CD4 count, that is follow up CD4 count, and send this patient back. If patient is doing well and there is no other OI, they will send this patient back to the Link ART center, medicines will be continued from the link at a center only. Even in the month of CD4 testing, medicines will be dispensed from the link at a center only. So, link at a medical officer should ensure that during this month, when the patient is due for CD4 count, patient should be given appointment in such a way that patient should not fall short of his or her medicine. In between 6 months, still link at a center can send these patients to the nodal ART center if they have any other major OI, or if the TB is diagnosed at LAC hospital, or if there are any side effects which cannot be treated by the link ART medical officer. So they can send these patients anytime in between to the nodal ART center. So now we understand that how simple is the treatment of PL-HIVs at link ART center. If there is any complication, you can link this patient back to the ART center. Only thing you have to do is do the examination every month and give the written medicines, written prescription which is there for the HIV patient, that is ARV. And if there is any minor OI which you are otherwise treating for the other patients, you can treat them. If you are think like you are of the thought that this thing I cannot manage at my hospital, or I do not have facility for investigating further, you can link this patient back to the nodal ART center. So when patient is linked back to the nodal ART center, what is to be sent with the patient from LAC? The updated white card Xerox, photocopy of the white card, green book, and that link in form which is to be filled. At this point, I will like to say that the white card is to be maintained at both the places in original. Previously, there was guideline that original white card will remain at ART center and LAC will maintain records in Xerox. Now we have changed guideline for more than 2 years. LAC will also maintain a separate white card, original white card. There will be 2 white card for the patient, those who are linked with the LAC. One will be known as the ART center copy of white card, the original white card in which patient was registered first at ART center and initiated on ART. At the time of linking this patient to the link ART center, they will do the Xerox of the white card, keep their original copy at ART center, and patient will be sent with the Xerox of white card and the original green book which is there with the patient to the link ART center. At LAC, from the Xerox of white card, they will prepare a new white card and that will be kept at the link ART center. When patient will be sent back to the ART center, they will send a photocopy of updated white card from which ART center will update their records. That is original ART center white card will be updated from this photocopy. So the CD4 count results will be shared by the ART center through email with the LACs, and ART center will do the clinical review of the patient, and if there is any other prescription, any other modification of drug regime, or they want to retain this patient at the ART center, they can retain. Otherwise, they will link this patient back to the link ART center for the follow-up of and further treatment. How drugs will be transferred from ART center to the link ART center? There are provisions under ART center grant and there are provisions under link ART center grant. At both places, there are provision of fund for the transportation of medicine. We have to ensure that medicine, sufficient stock of medicine for 3 months should be there at link ART center for the patients which are linked with the LACs. So this can be sent twice in a month. That if number of medicines can be sent on the 16th from ART center to the LAC. For the patients, those who are linked with the LAC during the first half of the month, that is from 1st to 15th, whatever number of patients were linked with the LAC, for them on the 16th of the month, they can send medicines, and then from 16th to 30th, whatever number of patients were linked, for them medicines can be transferred on the first of the month, first of the subsequent month. So twice in a month we can send medicines to the link ART center and ensure that for each and every patient they have at least 3 months stock. In case of shortage of medicines, medicines can be sent accordingly from the AIT center, that whatever stock is available, say if AIT center is having a stock of one medicine for 1 or 2 months, that same stock is to be maintained at LAC. There is no need like 3 or 6 months stock is lying at LAC and AIT center is not having stock of less than 1 month. So this distribution should be equal between AIT and LACs. There is a drug transfer grant given to LACs at the rate of 20,000 per annum, from which this TADA of the staff, those who are involved in the drug transfer from Linkati Center Hospital, this TADA of the contractual staff can be booked under this 20,000 grant. Drug stock reporting. Nodal AIT center will send drugs to the Linkati center, but they will not deduct these drugs from their stock, and LAC will report their monthly consumption, and based on this consumption, AIT center will report. So this consumption will only be deducted from the monthly report of the AIT center. So here is a issue of coordination. That is why the reporting month of LAC is kept earlier. It is on the 25th or 26th of the every month, so that they can send their report to the AIT center, and AIT center will compile their report and send it on 1st of the every month. So Link AIT center should send their drug related report timely, so that AIT center can prepare their monthly reports. These are the financial guidelines. These are the fund provisions under NACP for the Link AIT center. When we initiate Link AIT center, the fund given is 15,000, which is one-time grant for furnishing. It may not be like this is only 15,000 rupees. What maximum can be done is they can take some almiras or like things which are necessary. Otherwise, table, chair, everything is there. There is no need of refurbishment. Already hospital is having sufficient room, so one of the room can be designated for Link AIT center. If there is any furniture required, this can be procured within the limit of 15,000 rupees. This is one-time grant. This may not come again. And furniture and refurbishment, nothing can be done beyond the limit of 15,000. And recurring grant, this is coming annually. That is internal grant 7,800, stationery, record and contingency 10,000, travel and truck transfer 20,000. If it is LAC plus, then staff nurse will be appointed and the salary will be 13,000 per month. Nowadays, as we are facing shortage of funds and there are issues with the at some of the sites that Link AIT centers have not received any fund. I will request to look into these things. Is it like that without these fund provision from NACO, these things cannot be done from the hospital? Hospital may have already internet connection. From that connection can be provided to the Link AIT center. They may not need internet connection throughout the month. They may need it just for the emails checking and for the monthly reporting. So that may not be a big task for a hospital where a lot of other things are being done regularly. So I don't think so that if once in a while the grant was not provided, Link AIT center may not be able to work. Then stationery record. How much stationery and record will be required for a Link AIT center? There is already existing phone connection with the hospital, and there is a office setup in the hospital. They have stationery. They have the sufficient stationery in the hospital, so they can provide this thing for Link AIT center also. Drug transfer and traveling, it may they may need some fund for the this thing. It may be a mutual understanding between AIT and LAC. There are centers where regularly someone is coming from the sub-district level hospital to the district hospital, like ambulance is coming or some officers are coming for the meetings and something. So these medicines can be sent in these vehicles. Otherwise, AIT center can book their this drug transfer fund under their contingency grant if LAC was not getting funds. But from this year onward, as NACO have assured that now the fund flow will be smooth and we will get the funds, so I think there may not be any issue. But we should think of about the convergence in future for this. These minimum things which are there in the hospital, they can easily provide. So why to depend upon a NACO fund for these small issues which can be dealt easily in the hospital. This is how patient will travel in the hospital once found positive at ICTC of the hospital where it is designated as LAC plus. So the patient will go to the staff nurse of LAC plus, get registered under HIV care, that is the pre-RT register. Filling up of white card will be done by the staff nurse, and then patient will be sent to the counselor. Counseling will be done on the positive prevention, nutrition and other things. Then patient will be sent to the medical officer who will examine the patient, do the baseline workup, screen for TB and send this patient to the staff nurse for the TB line list if required and referral to RNTCP. Then baseline CD4 sample and other investigation sample will be collected by the lab technician, and staff nurse will collect the reports, and if they found patient eligible for ART, they will link this patient back to the ART center, and ART center will start ART. So patient will be registered at LAC from ICTC directly as a LAC plus center. Now, how this patient will get the pre-ART number which is given by the nodal ART center? Then lab technician will collect the blood sample for baseline investigation and for the CD4 testing. This CD4 sample will go to the nodal ART center for testing. At this time, lab technician will send the details of the patient along with these CD4 samples. Based on the referral form details received with the CD4 sample, this patient will be registered at the nodal ART center in pre-ART care, and the pre-ART number will be given by the ART center at that time of receiving of CD4 sample. This number will be communicated with the LAC plus, which will be the pre-ART registration number of the patient. Whatever number is given at LAC, that will known as LAC number, that is not as pre-ART or ART number. Pre-ART number and ART number are given only by the ART centers. As we discussed, white card will be maintained at both the places, LAC and ART. Again for LAC plus, similarly, they will maintain white cards at both the places. So what are the baseline workup for PLHIV, those who are in pre-ART care? So at LAC plus, essential tests which are to be done for the baseline investigation like hemogram, CBC, urine, routine, fasting, blood sugar, blood urea, SGPT, VDRL, chest X-ray and CD4 count. These are the mandatory investigations. If required, pregnancy test can be done, screening for TB by the 4S symptoms, and if there are any symptom and signs for any OI, then whatever investigation required to rule out OI can be done. If any of the investigation listed in this slide like chest X-ray or some of the investigation may not be available at the sub-district level hospital, so in that case patient can be linked to the ART center, or blood sample, if it is blood sample, the blood sample can be sent along with the CD4 sample for the testing. If like chest X-ray is not able to not available in LAC plus, so these patients can be linked to the nodal ART center for chest X-ray. It may be the first one time only, because it is to be done at baseline workup only. Afterward, if there are any TB or something like suspected respiratory tract involvement, then only chest X-ray may be required. So this is the 4B format which we discussed about the O negative patients, which is to be maintained by the LAC and LAC plus. This is Excel sheet format. It is to be maintained in soft copy at both the places, ART and LAC centers, and every month they have to take the printout of this updated format, which is to be maintained in separate files at LAC, LAC plus and ART center, and soft copy need to be updated every month by the LAC and ART centers. Similarly, there is a 4C format. which is to be maintained by the LAC Plus for pre-ART patients, and it is to be updated every month by the LACs and by the ART center. And printout of this format is to be maintained in separate files at both the places, LAC Plus and ART centers. There are chances that treatment records are remain incomplete. And what may be the possible reasons behind these? Because the patient is traveling with the Xerox paper of white card, and ART center staff is negligent about the monthly 4B, 4C updation. They are getting the Xerox at 6 months interval, then only they are doing updating their records. So this may not be a routine practice. They should update their records from the monthly 4B and 4C format. If it is, and it should be ensured both at LAC and ART center that 4B and 4C is to be regularly updated, and based on which they can update their records at both the places. Monthly report of linked ART center have to be sent through email on the 25th of every month. The reporting cycle is 26th to 25th. So on 25th evening they have to send their monthly report to the ART center, and ART center will compile their report and will send it to the SACS and NACO. There is no direct reporting from linked ART center to the NACO unless specifically asked for. This is the monthly reporting format of linked ART center. This first page is having demographic information about the LAC, address and city and reporting period and name of in charge and contact detail, nothing else. This is only for the LAC Plus. There is no much complication in this format. Simple, easy to understand, self-explanatory indicators. Just there may be some confusion between 2.4 and 2.5. That is number of PL-HIV in HIV care linked into nodal ART center during the month. These are the patients, those who are linked in during the month, for maybe for the initiation of ART, maybe because of some OI or maybe because of CD4 testing. So these are the patients, those who are linked in during this particular reporting month only. This is not a cumulative thing, this is just for the month. And 2.5 is cumulative number of patients, those who are linked in and retained at the end of month. So this is total those who are retained once they were registered with LAC, they were linked in, they were there in 2.4 of some month, but now they are not returned back, they are retained by the nodal ART center as on today. This is cumulative figure. Since the beginning of LAC Plus, those who are linked from the LAC Plus to the ART center and retained by the ART center till the end of reporting month, that will come in 2.5. 2.4 is dealing only with the current month linked in. It is not asking about the retaining of the patients. It is just the linked in. It may be retained, it may not be. But 2.5 is cumulative patients, those who are retained at nodal ART center out of those who are total linked from the LAC Plus. So that is the difference. So 2.5 is deducted in while calculating 2.8. 2.8 is auto generated. Number of PL-HIV in HIV care at LAC Plus. This is total of 2.3. That is the cumulative number in registration till the end of month. This again 2.3 is a total of 2.1 and 2.2. 2.1 is the last month 2.3 and 2.2 is new registration during the month at LAC Plus. So that is 2.2. So 2.1 plus 2.2 become 2.3, and out of 2.3 if we reduce 2.5, that is retained at nodal ART center, 2.6 that is lost to follow-up, and 2.7 that is died. So out of 2.3 if we reduce retained, died and lost to follow-up, that will be the number of patients those who are in HIV care at LAC Plus at the end of month. That is 2.8. It will be auto generated. Then is total number of patients undergone baseline CD4 count. It may be like this is LAC Plus center. This it may be like some patients those who are registered at LAC Plus directly from ICTC of the hospital. Maybe some patients those who came from other nearby ICTCs. Maybe some patients those who came from ART center in pre-ART care, they were already underwent baseline CD4 count. So whatever, from wherever patient is coming, if they underwent baseline CD4 count, at whatever place, even by the referral of LAC or without referral of LAC class, they underwent baseline CD4 testing, they should be there in 2.9. So if a patient is referred, linked as to LAC plus in pre-IAT care from AIT center, already underwent baseline CD4 testing, this patient was never sent from LAC plus to AIT center for baseline CD4 testing, even though this patient will be included in 2.9. It was not sent by LAC plus, but actually this patient underwent CD4 count. So total number of patients who underwent CD4 count is 2.9. Out of that, how many were eligible? That will be 2.10. And out of that, how many are ever initiated on ART? This part may not be in line with the upper part of 2.1 to 2.8. This may be a different data, and lower part may be a different thing. But 2.12 will be out of 2.8. Those were new antenatal cases reported in HIV care this month. So this is very simple monthly format. There is one question from ART, no missed patient to be considered in the monthly LAC report. I could not understand what, if you are talking about the missed patients, I will go to the own ART part. You will understand here now. So this is related to the ART own ART patients. 3.1 to 3.3 is similar to the LAC plus. That part is only for the pre-ART patient. If this is LAC only, there is no need to fill up the second part, that is the previous page of the format. That belongs to pre-ART patients only. So this is for the own ART patient. This is to be filled by both LAC and LAC plus. 3.1 is number of own ART patients which are there at the beginning of this month. It means it is 3.3 of the previous month. Those who are linked with the LAC. And 3.2 is the current month linked out, those who are linked out during the month with the LAC, and 3.3 will be the total. Now 3.4, similarly, those who are referred back to the nodal ART center during the month, maybe because of side effect or major OI. 3.5 is cumulative retained at the nodal ART center. 3.6 is loss to follow. 3.7 is death, and 3.8 is miss. So miss we have to report in 3.8. But it may not be detected while calculating 3.9, that is total number of PLHIV alive and own ART. You can see that out of 3.3, those who are cumulative number of PLHIV ever linked out with the LAC, out of that we will deduct retained at nodal ART, we will deduct the 3.5 that is retained, 3.6 that is loss to follow, and 3.7 that is death. So out of 3.3 we will deduct these three indicators only. We are not deducting miss, we are not deducting current month linked back patients from calculating total number of alive and own ART patients at LAC. So then out of 3.9, those who are new ANC cases, that will be 3.10. This is regime wise distribution. This part is similar to the ART center reporting about the adherence, how many were assessed for the adherence, how many are not. So those who are not been assessed for adherence will come in 4.1, and those who are assessed, out of that how many have been assessed, how many were having more than 95% adherence, that will be 4.2A, and 4.2B will be the percentage that will come automatically. This is regime wise distribution for adult and pediatric, as we have only first line regimes, so there may not be any second line patient. So this first line regime will be there in the regime wise breakup of patients alive and own ART should be there. Then this is about the drug stock. It's just simple format like opening stock of the particular drug for the month. Then during month if received any stock transferred out, reusable stock patient returned from the patient, that is sealed bottle received from the patient. Consumption during the month, expiry, and stock at the end. So stock at the end will be opening plus stock received plus reusable stock minus stock transferred out minus consumption and minus expiry. So this will be the stock at the end of the month. So is there any OI reported? That OI will be number is to be reported in 7.1 and that breakup is to be reported in 7.2. Again, side effect breakup is to be reported if there are any side effect reported at link AT center. Staff of LAC have to be reported in this part, since when they are in job, whether trained or not. If vacant, then since when it is vacant. How many times patients were linked back to the AT center before their CD4 count because of CD4 because of any side effect or major OI or any other reason. That breakup has to be given in the section 10. So what will be our way forward? With this, I think we will be moving toward the integration with the NHM. So we will integrate with the HIV care services with the primary and secondary healthcare system. We will do this by capacity building of the healthcare providers at primary and secondary level hospital staff, and by this the ownership and quality of services through the sub-district level hospitals will be improved. If once this ownership will come, quality of services will improve further, and the gap between ICTC and ARTC will be decreased. And with the help of this improved ownership and improved quality of services, access to the ART services will be increased. Patient will get ART services near to their home, and ultimately adherence will improve. And with this, we will be able to reduce morbidity and mortality in PL-HIVs coming at LACs and LAC plus. So I request all the link AT center medical officers who are there in this presentation, they should take the ownership and try to think why there is no need to afraid of these things. These are very simple things which are to be done. You are doing lot of work, lot of complicated patients you are managing. These are simple patients, have to be done 2-3 things only. And if there are any complications, you can link these patients back to the ART center. But try to do these simple things at your LAC so that adherence of patients can be improved, access to the services can be provided at the sub-district level hospitals. Thank you. If there are any questions, we can discuss. As we sort of, I think time is over. So if there are any questions, we can discuss.
Thank you so much for the valuable session, sir. And then I'm requesting all the participants to kindly enter the e-poll displays on the screen. And then thank you all the participants for the patient listening. Once again requesting all the participants to kindly enter the e-poll displays on the screen. Thank you so much.